Live from New York, it's Benefits with Friends. I'm your host, Lou Bernardi. Thank you for joining us today. We have an excellent show. Um, Great guest coming on. I'll bring Dr. Jonathan Kaplan on shortly. So for those of you who are new to the show, new to Benefits with Friends, pull up a slide here, kind of tell everybody what we're all about. So I'm a 30-year benefits veteran, general agent, advisor. Recently rebranded myself as a BOO, a benefit optimization officer, because I really am. I don't really consider myself to be someone who just sells insurance. That's really kind of failed the system for quite a long time. So, benefit optimization, as the name implies, is the process used by HR professionals to critically assess an organization's benefit structure and determine what changes can be made to make the benefit package on offer best serve the organization and the employees. And I think that's what all benefit managers, chief HR, HR directors, anyone who kind of leads the benefits and HR of their organization really is aiming to do. But it's challenging, right? The system is kind of rigged against employers, their members, especially as it relates to employer-sponsored health plans. So this show is dedicated to try to, increase everybody's healthcare IQ, health insurance IQ. And as I see it, there's kind of 8 core issues with the status quo benefit plans. And it's a lack of price transparency, a lack of quality transparency, very low provider-patient engagement, 30% markup in prescription costs or more. We've seen as much as 53% in some of the analysis that we've done. Healthcare steerage by a very predatory healthcare system, not talking about doctors. It's just the system that we all work within and that doctors work within. Misaligned incentives. Everybody makes more money when premiums go up, and premiums go up when claim spend goes up. So we're really here to try to help benefit advisors, HR directors, CFOs, even employees better understand the whole ecosystem of healthcare and health insurance. No control of plan documents, kind of a little higher end thing, but plan document basically dictates everything under your group health insurance plan, what's covered, where it's covered, at what level it's covered, and also unnecessary care. So that's enough about me. I am going to introduce our guest for the day. And our guest today is Dr. Jonathan Kaplan. Dr. Kaplan is a board-certified plastic surgeon. He's based out of San Francisco, California. He's the founder and CEO of Build My Health, which is a price transparency lead generation platform for doctors. And it's really cool. I'm going to bring Jonathan into the stream right now. I'll close this slide here. Dr. Kaplan, how are you?
Great to be here.
Yeah, this is awesome. You're on the other side of the country, on the West Coast. I don't know what the weather is like by you, but it is
beautiful. It's always beautiful.
It seems to always be miserable on a Thursday here. I don't know what it is. I was so excited it was going to get up to 60, but the wind is howling, and I'm sure it's going to rain at some point. But yeah, thanks so much for taking time out of your day to join us. I know you're a busy guy. We were speaking a few moments ago. You were in surgery this morning, so really cool. It's noon by you. Is that correct?
Correct. Yep. Exactly. Yeah. 12:04 now.
So So tell us, everyone out there, a little bit about you. I think this is the first time we've had a doctor on the show. So what do doctors' insurance have to do with one another? So by all means, please introduce yourself.
And they might be even more confused that I'm a plastic surgeon if they think it's all cosmetics. What does that have to do with insurance? But we'll definitely get into that. But yeah, I'm originally from Alexandria, Louisiana, born and raised, and then I went to the University of Texas for undergrad, came back to Louisiana, did med school at LSU in New Orleans, general surgery residency in New Orleans, and then went to the Cleveland Clinic for my plastic surgery training, and ended up back in Louisiana for my first 6 years of practice. I was employed by a hospital in Baton Rouge, Louisiana, Our Lady of the Lake Hospital. And it was great. It was like, my first position was like employed by the hospital. It's a great way to kind of get started with your career. You're not having to worry about paying a lot of bills and things like that. You're not trying to run a business at the same time as you're trying to be a doctor. So that was a good way to start out my career, being with Our Lady of the Lake. And now, 8.5 years ago, my wife and I moved out here to San Francisco. I took over an existing practice with its own in-office operating room. So we live in the neighborhood, so I'm able to walk to work every day. Actually, it's uphill, so I get my exercise walking uphill. It's very hilly here in San Francisco, but I walk to the office, operate, see patients, and then go home in the afternoon. It's all very convenient, very self-contained, having our own accredited operating room here in the office.
Oh wow, it's incredible. Just to let everybody know. So I actually was in Phoenix at a U-powered benefit symposium a few weeks back and sat through one of your sessions, and I was just blown away by your knowledge of some of the things that we're going to talk about today, and especially the perspective from the other end, right? I tell people all the time that I've been selling benefits for 30 years, but it wasn't until 5 years ago that I really connected the healthcare and the health insurance. I sold health insurance. I was very good at it. Helped thousands of employer groups over the years, especially in my role as a general agent, where I was essentially a broker's broker, helping them sell to their clients. But we were always so focused on the insurance because we didn't have any access, just like the consumer, right? There's no access to the healthcare costs. So the narrative is, in the common sense, you think, well, we're dealing with the largest insurance carriers typically. They're dealing with the largest pharmacy benefit managers, which either own the carriers or are owned by the carriers. They must be getting the best prices. So the thought was, the claims are the claims. I've heard it, hundreds, if not thousands of times over the years. So it's just like, well, the claims are the claims. If you go from company A to company B, meaning insurance carrier A to insurance carrier B, you're going to pay the same amount. They're just, the underwriters are being creative. And 5 years ago, on my new journey, the path towards rebranding our agency, Bright Path, was, we just thought we were in the dark and there was no better way. But there's an entire separate ecosystem of healthcare and health insurance. I mean, doctors are just as dissatisfied with this kind of the status quo managed care system that they operate in. And so I couldn't wait to ask you to be on the show. I'm so happy that you agreed to join us. I'm gonna pull up a slide here in a second, because the kind of the core of what we're going to talk about is price transparency, and then you're going to show us in live almost how that's going to look, because people haven't seen this before. You're so used to going to the doctor, that's part of your network, not even discussing price up front, not discussing quality up front, how you got to that specialist or that doctor, a variety of different ways, referrals from friends, the doctor that, your primary care doctor, if you're lucky enough to have one that you can actually get in to see, refers you to somebody, but you don't know anything about the quality of that doctor. And the doctor's offices up till now have just always said they can't tell you the price. They can tell you maybe what they're going to charge, but they have no idea what's going to be covered. So, you have a consumer in healthcare that usually finds out when it's way too late what it ends up costing them. When they get their invoice or their explanation of benefits and it says, applied towards deductible, co-insurance, member responsibility, could be a really significant amount, especially if you're unlucky enough to get to and we'll talk about the No Surprises Act, a doctor that's not part of your network, right? Because those doctors, in theory, could charge anything they want. Your insurance company is going to, if you have a PPO or a point of service plan, they'll reimburse you something if you have that kind of, and it's usually a percentage of Medicare, which is significantly lower. So there's kind of, I don't know how much the people out there who are watching are aware of these things, but there's some really significant legislation. We're not going to get really, this isn't a conversation to get really too deep in the weeds about these things, but transparency and coverage rule was actually signed back in November of 2020. Actually took effect this year. Actually, I think it was really December 27th of 21, technically, and encompasses a lot of different things. Part of it is being the enforcement of is being delayed because there's a lot of unanswered questions for insurers, for the healthcare system, for employers, for advisors. But it's here, and we're expected to comply with things. We spent a pretty good deal of the last week or two in my office preparing our compensation disclosure forms, right? And a lot of people out there, especially employers and benefit the decision makers, probably aren't aware that their brokers, consultants, advisors, benefit optimization officers now need to give them compensation statements prior to their new plan or their renewal date to let them know every penny of compensation, where they're getting it from. It's no longer just commissions that are reported on a Schedule A that goes on a 5,500. If you're getting overrides, if you're getting $1 a head on COBRA administration, or all these different ways of really kind of hiding compensation, which is really the root of the misaligned incentives, those things are coming as well. But this transparency and coverage rule is really interesting to me, because what they say is the rule intends to improve price transparency in healthcare by requiring that employer-sponsored plans provide enrollees with cost-sharing information, including estimates of their out-of-pocket expenses, right? A lot of this burden is on the employer. Now, if you're fully insured, your insurance carrier is supposed to be helping you comply, and you can enter into kind of an agreement that they're going to be the source of that. But I don't hear a lot of commotion from the insurance carriers talking about much of that, right? They're not looking forward to this. Price transparency is not something that health insurance companies can make more money doing, right? They don't want an informed consumer. They like the system the way it is. And certainly the healthcare system likes that as well, right? They take advantage in many different ways. So the rules specifies why it's important. So the 4 bullets really is consumers can make more informed decisions, right? They need data to do that. You can't do that without data, right? You don't know where to go to buy a TV if you can't go online or pick up a brochure or something, or go into a store and see it labeled on the shelves, right? 55-inch flat screen TV, $450. I'll take it, But if you just take that TV and walk to the register, swipe your Amex card today and wait 3 weeks for a bill to find out how much it's going to cost, that's kind of the way healthcare works today. You find out after you've used it and it's not returnable. Stakeholders are better able to help consumers, so doctors, patient advocates, things like that. The risk of a surprise bill is reduced. So the No Surprises Act is part of this, but the transparency and coverage rule expands on it beyond just like emergency room and out-of-network services. Competition increases, which is something I think that's probably near and dear to your heart, right? You want competition in the physician space. And then obviously there's gaps in state regulations. So having a federal regulation that kind of is all encompassing provides at least a minimum requirement. Certainly I think some states will do better than others. And then key components, right? So this is going to require insurers and employers, especially self-insured employers, to disclose rates and cost sharing. They're going to have to provide machine readable files that are not behind passwords. They're public disclosures of this information. It's going to have to show negotiated rates for in-network contracts and allowed and bill amounts for out-of-network contracts. Interestingly, and we talked about this briefly before, the prescription component, the historical pricing on prescriptions, has been indefinitely postponed. And I found there was about a month ago, the Federal Trade Commission voted 2-2 not to explore the pricing of pharmaceuticals. And I thought that was very interesting. I think they have significant lobbying power right now. And price transparency tools are going to be mandated. Employers are going to be responsible to give their employees tools to make them better shoppers. And that starts January of next year and also expands in 2024. So I know that you're kind of a specialist in the No Surprises Act. That was the portion of your presentation at Phoenix. So I'm gonna leave this slide up, but I'm gonna let you talk about the No Surprises Act.
Yeah. Now, and also the kind of the background of how I got into all of this price transparency is that back when I was employed by Our Lady of the Lake Hospital around about 10 years ago, I had this idea, patients were always calling asking about pricing, how much things cost. And the way most doctors do it now is like, oh, like our plastic surgeons do it now is like, oh, well, you got to come in for a consultation before we know what you're going to get. And then we can tell you the price. And that just aggravates the consumer because they just want to know whether it's worth coming in to disclose my deepest insecurities about my body for a cosmetic procedure, only to find out that I can't afford it at the end.
Right.
And I just realized that was a silly way to do it. And the thing is, when the patient comes in, eventually they talk to the office manager, the cosmetic care coordinator, who has a fee schedule. They know all the prices of all these things. I mean, sure, maybe they don't know the specifics in your particular situation, but they have a really good idea of how much it's going to cost. And I thought, we should digitize this. We should find a way for the consumer to be able to check pricing before they come in. And they provide us their contact information in exchange so that we can follow up with them and answer any questions, make sure they chose the right procedure. And so that's how I initially had that idea. I started this company because I was employed by the hospital. They actually had the intellectual property for it. So they signed over the intellectual property to me, because you can imagine in 2009, if hospitals aren't terribly interested in price transparency now, they definitely weren't interested in price transparency 10 years ago. So they signed over the intellectual property rights to me. And then so once I left the hospital and came to San Francisco, I was able to bring that with me. All throughout that time, the U.S. Senator who I wrote that Newsweek article with about the No Surprises Act, Bill Cassidy, well, he started out as one of my professors in medical school. And then he went on to become a state legislator, and then he became a U.S. congressman, and now he's a U.S. senator. And all throughout that time, we stayed in touch, and he was always championing my efforts with my company, Build My Health, as far as price transparency. So we've stayed in touch this whole time. And then he was actually one of the co-authors of the bipartisan No Surprises Act. And once that went into effect January 1st, I realized this was a good time for the two of us to come back together. And so that's why we wrote that article on the No Surprises Act that was published in Newsweek. So I'll go ahead and get started, and I'm going to share my
that's
screen.
Interesting. Yeah, no, I didn't know about that connection. I'm glad you shared.
Yeah, that was kind of the background of how it all started.
Yeah.
And so we've stayed in touch, and he's definitely been a champion of price transparency throughout all of this. And just let me know if you can see my screen right now.
I'm going to bring yours on. There we go.
Great. So anyway, the No Surprise Act, which he co-authored, which Bill Cassidy, the U.S. Senator from Louisiana, co-authored, it was passed in December of 2020, but it is the law of the land as of January 1st. Doesn't apply to Medicare and other federal programs because they already have their own surprise billing protections in place. And then this law, and the thing is, from a plastic surgeon's perspective, a lot of us didn't think this applied to us. We only thought it dealt with emergency situations. And that's what most people think, that they think the No Surprise Act really only deals with people when they go to emergency room, that they don't get a surprise bill because somebody at that hospital was out of network. Well, that's that the No Surprise Act does deal with that if you go to an emergency room, it's an emergency, whether or not the ER doctor's out of network or the radiologist out of network or the anesthesiologist out of network, they can no longer send you an out of network bill. With the No Surprises Act, they have to send you an in-network bill. What that in-network bill has been up for some litigation, but the idea is it's going to have something to do with the median in-network rate. It's going to have something to do with what you've been that doctor's been reimbursed in the past. It's going to involve the complexity of the case. So that's what the in-network rate is still up for discussion, but they're going through that. Like I said, CMS lost in some litigation, and so they're going to come up with some more clarification on that. But that's one aspect of it. In an emergency situation, you're only going to get in-network bills. The other situation was that if you're going in for a non-emergency situation, then you would be able to still, as a doctor, you could still bill out of network in a non-emergency situation as long as you got consent ahead of time. But then there's also doctors that even if you choose to get consent, you still can't. You're not allowed to. So, for example, if you're a patient, you're going in, you're choosing to have this particular breast reconstruction or hip surgery by this particular plastic surgeon or orthopedic surgeon, and you know that they want to charge you out of network, and they and you sign a consent form that CMS says if they sign this consent form, then yes, you can bill out of network for that particular service. You've gotten consent, And you also have to provide them with the pricing information ahead of time. That's another big key factor. You have to give them an idea of what their costs are going to be. But there are situations where if you're the patient, and I mentioned you choose the orthopedic surgeon, you choose the plastic surgeon. Well, if you don't really have a choice of the doctor, then that doctor cannot bill you out of network. So, for example, you go in for surgery and there's an anesthesiologist. Well, you didn't really choose the anesthesiologist. So
Right.
even if they wanted to get consent, they're not allowed to. So that's another aspect of the No Surprises Act that protects you. But it really does apply to everybody. One of the things that the way to break it down, the way I find it easiest to think about it, is that they're trying to avoid surprise bills by informing people of the cost ahead of time. So that's where price transparency comes in big on this. And that's one of the things I was saying in my Newsweek article with Senator Bill Cassidy, is that I feel like the No Surprises Act is like the Trojan horse of healthcare bills, because on the outside, it looks like it's just about surprise bills, emergency situations.
Right.
But the truth is, packed on the inside of it is a ton of price transparency requirements for both people that are using insurance. So they want to reduce surprise bills for people using insurance by providing them more pricing information up front. And then it's also addressing people who are not using insurance and to reduce surprise bills for them by providing them with pricing information. And so that means you have to provide some estimates for these people. And everybody refers to it as the good faith estimate, but that technically only applies to people who are dealing with cash rates, cash pay. And that can be cosmetic surgery, but it could also be somebody who's got insurance and choosing not to use their insurance if they're getting, like, they find out that an MRI is less expensive if they just pay cash versus going through their insurance. And of course, the good faith estimates are also for uninsured. So as you can see in this slide, there's two different types of estimates. There's the out-of-network estimates. So that's people who have signed the consent form in a non-emergency situation and are agreeing to pay the out-of-pocket, the additional out-of-pocket cost for the out-of-network service. And if the doctor is doing that, they have to, of course, give them the consent. But then the estimate that they have to provide price transparency ahead of time. They have to provide put the patient's name on there, the CPT codes, the cost for that provider to provide that service. And you also can list other available in-network providers. So just to let them know that, you don't have to come to me as the out-of-network provider in this non-emergency situation. The other aspect of it that's not implemented yet is the advanced EOB. They've got to build out the technological plumbing for this first, so they haven't done it yet. But if we're talking about out-of-network estimates, right now, the provider, the doctor, only has to tell the patient what their cost is going to be. In the future, eventually, I would then send that estimate into the insurance company, who would then determine the OR fees, the anesthesia fees based on historical data or negotiated rates. And then they would send that patient an EOB, an explanation of benefits, beforehand. So that's why it's an advanced EOB, because it's before the procedure, as opposed to just give them the explanation of benefits after the fact when it's too late.
Right.
So again, the advanced EOB is not implemented yet. At the very least, right now, if you're going to an out-of-network provider, they have to provide you with an out-of-network estimate for their cost. Now, that's in contrast to if you're not using insurance, for all the reasons I stated before, that you're uninsured, you're choosing not to use your insurance, or you're doing a cosmetic procedure. You are now required to get a good faith estimate from your doctor. Well, the doctor's required to give it to you. You're entitled to it, and that's going to have your name and the doctor's tax ID number, NPI number. I'm not exactly sure why it has to have the tax ID number, but it does. You have to have the diagnosis code if one exists, the CPT code if one exists for the particular procedure. And you have to provide all of the costs. So in contrast to the out-of-network estimate, where it's just the provider providing their cost, with the good faith estimate, the doctor has to provide everybody's cost. So my fee as the surgeon, the OR fee, the anesthesia fee. And the thing that's funny about this is that with this good faith estimate, with the No Surprises Act, the plastic surgeons doing cosmetic surgery didn't think it really applied to them. As I mentioned before, they thought it was just about emergency surprise bills with insurance. But even though they didn't think it applied to them, they're actually in the best position to provide a good faith estimate, because for cosmetic procedures, we were already providing the consumer with our fee, the OR fee and the anesthesia fee, because typically those were fee schedules we could get ahead of time, and they were based on time for cosmetic procedures. So just kind of funny with the plastic surgeons, they didn't think it applied to them, but they were actually best positioned for it. So what I keep kind of telling patients and doctors that they should be able to do is don't look at this as a negative of having to deal with the price transparency. Think of this as a way to improve your office workflow. Take this as a benefit or an opportunity. And so what we're doing is, in addition to the patients coming in for the consultation and then providing them with their out-of-network estimate or their cash pay estimate, we're allowing the consumer to get that estimate online. We're taking a page out of the credit card company's playbook that, in the past, when you went to a drugstore, convenience store, grocery store, you had to hand your credit card over to the employee because they were the only one who was especially in service to run your credit card. Like, you couldn't do it, they had to do it.
Right.
But now, as we know, we're running our own credit card or Apple Pay or Samsung Pay. And so that's what I'm suggesting, is taking all of this responsibility from off the shoulders of the doctor's back office and shift that to the front office, to the website, to the front end, so that the consumer can check pricing. And then once they come in, then you can do the consultation and adjust the estimate as needed. And then provide the patient with their out-of-network estimate or their good faith estimate. So I'm just going to show you, if it's okay with you, I'm going to show you an example of how the patient can check their estimates on our website before they come in. And I'm going to show you both for cash pay and for insurance. And even though the examples I might be using deal with plastic surgeons, I want to convey I want to emphasize that the cosmetic procedures, just think of them as any kind of bundled rate for any procedure. Like if you're getting arthroscopy, so it's not just about cosmetic cash pay, it's also for bundled procedures that are not necessarily cosmetic, that are medically necessary, that are elective. And I'm also going to show some examples of insurance-based pricing, of how the consumer can actually check their out-of-network price.
Okay.
So here's my website in San Francisco. The consumer comes to my website, and then they can open up this chat bot. And if there was insurance-based services, they could choose their insurance plan. But in this example, we'll just choose a breast category, and then they can choose breast augmentation and lift. Again, could just be a cash pay, medically necessary service, doesn't have to be cosmetic. And the patient puts in their email address and their contact information, and then we immediately email them automatically. Our system automatically emails them an estimate. This is what the email looks like. The patient gets it, they see the procedure they're interested in, a breakdown of all the costs, so the OR anesthesia and OR fees. And then we get the patient's contact information. We can follow up with them, make sure that they chose the right procedure, make sure they don't come in thinking the price is one thing and it's another, because we don't want anybody to experience any kind of sticker shock or bait and switch situation. And
Right.
then once they come in, our office staff can take that estimate that the consumer's already put together for themselves, and rather than us having to create a new quote from scratch, again, this could be for bundled rates procedures or cosmetic procedures, we can find that patient's estimate, the one that we just submitted through the chatbot for a breast augmentation, enlargement, and lift. And my office staff can then pull up that estimate and switch it to the good faith estimate, which has a lot of requirements. So that means that we have to, as I mentioned before, you have to include my tax ID number, the patient's address, the diagnosis code, even if it's a cosmetic procedure. And then we can actually take that estimate that the patient's already created, convert it to a good faith estimate. We can email it to the patient, but since they're there in the office, we can print out a really nice estimate, which we're required by law to do now. That includes the CPT code, if one exists, a breakdown of all the pricing, and this disclaimer that CMS says we have to include. The disclaimer for a good faith estimate is just saying that if the bill is more than $400 than what you expected after the fact, then you have a right to launch a dispute. And so this is all kind of packaged together for the office staff to do that for a cash pay service. Now, shifting gears, and let's talk about insurance. We're still letting the consumer do that on the website before they come in, so they can look through. This is, again, our price estimator on our website, similar to the chat bot, just a little bit more fully functional. And they can choose their insurance plan, United PPO in this example, and then they can choose a category. We'll talk about breast reconstruction, could be anything though, and they or any kind of elective procedure. And then we allow the consumer to put in their deductible, their out-of-pocket maximum, their co-insurance, if they know that, but they probably don't know that. So we give them the opportunity to just put in their member ID number from their card and their first name, last name, and date of birth. And all of this is what I'm doing here. People will recognize is the real-time eligibility that this is the real-time eligibility that people can take a look at, and they can see the pricing there on the screen, and then they can actually see their deductible prior to the service, their out-of-pocket maximum. All of this is done the real-time eligibility that your back office staff would be doing. Now the consumer's doing it. They see their co-insurance, and you can see the estimated out-of-pocket cost and the amount your insurance pays. And here you go. You can see the email that we send to the patient, breakdown of all the pricing, and with their out-of-pocket estimates, so that they see that. And the beautiful thing about this for the patient is that one is they get a better idea of how much things are going to cost. They also recognize that insurance doesn't pay for everything. The second thing is that if a patient comes in with insurance, they think that, I don't know anything. And then you think about how upset they get when they realize they owe a $40 copay. And so you think about if they're upset about a $40 copay, they're really going to be upset about an $300 out-of-pocket cost. And
yeah.
And so then the third benefit is now that they have a more realistic understanding of the cost, then when they do come in and they see the doctor and they have the consultation and they go to talk to the business manager about what they're going to owe out of pocket up front, then they're not going to yell at the business manager because they already saw what the cost was going to be ahead of time or had a good idea of the cost. And then going back to what happens when the patient does come in, we can adjust these estimates, because they don't necessarily choose the right procedure. This was a breast reconstruction procedure I showed in that example. And then we can, our office staff can switch over to that out of network estimate so that we can apply their out of network benefits. And then of course, all the things that CMS requires is their birth date, their address, their phone number. We have to choose a diagnosis code for those out of network estimates. These are all things that CMS requires. It's not just things I'm just choosing to add to the quote.
Right.
And then let's say the patient chooses the wrong procedure, as I mentioned, then we actually have the ability to switch out that procedure and add in the correct procedure. And remember, because the patient put in all their insurance information up front, then we are able to just resubmit their real-time eligibility all again, because we have their member ID number already, create that quote with the updated procedure. And now we can see a breakdown of all the pricing and all of their out-of-network responsibilities. And then we create a quote that, again, has all of the necessary things that CMS says that we have to have, the diagnosis code, breakdown of the price, and CPT code if it exists. And it's just a nice looking quote that we can create for the patient in our office. And we have other doctors using this platform, of course. But yeah, you can see how it just shows all the different out-of-network benefits. And that surprise billing protection form, that consent form that I said you had to have now for out-of-network services, that's all included in this quote. And then the patient signs that. And now the doctor can send an out-of-network bill, and they can even balance bill if the allowable doesn't reach the amount that the doctor was charging for the procedure. So as long as you get the consent, you can send an out-of-network bill. You can actually balance bill. It's not considered a surprise bill anymore because they've signed the consent. You've given them an estimate up front.
Right.
So if anybody has any questions about all that, you can just email me, at jonathan@billmobile.com. I know you're going to put up our information at the end. But a lot of those things I just went through, like the disclaimer for the good faith estimate, the consent form for the out-of-network billing, those are all things that we have access to. Because that's the other thing is for doctors, they have to post these by their front desk now. Wherever patients check in or schedule an appointment or pay a bill, you have to have those kinds of things posted now on the front desk or by the front desk. So let me jump out here and I'll stop sharing my screen.
Yeah, I'm going to pull up another. I'm going to pull up another slide here because just to put this in perspective. I mean, and that was amazing because
that was a very fast. I usually do like a 1-hour webinar on everything I just talked about.
You went through it in record time, I'm sure. But so I pulled these stats up, right? So how common is surprise billing, right? So and this came right from I think from a website, SentryHealth.com, that popped up when I did a search earlier. Let me reject that call. So nearly 40% of emergency department visits to in-network hospitals result in an out-of-network bill. So 40% of the time, even if you're in-network, this is the emergency room component of it. 40% of the time, you end up getting a bill from a provider that wasn't in-network, that you have may not even have known that you saw the doctor. Right? 30% of inpatient admissions to in-network facilities result in at least one out-of-network bill, with the average bill being about over $2,000. That's a lot of money. I think statistically, 70% of the population has less than $1,000 in the bank. And this is really interesting. I don't know if this is something that you have any kind of insight in, but there's several states that have 25% or more of all their ER visits end in with some sort of out-of-network billing. New York, Texas, New Mexico, California, Kansas, New Jersey. And then there's several that have less than 5%. And I don't know if that's because of state regulations in those states that prevent that more than others. I know that over the years of being, in the benefits business, one of the most common, billing issues that we ran into was surprise billing. And, a lot of people didn't realize that when you go into the hospital, that's one building, but there's many different entities within that hospital under different names, tax ID numbers, right? Perhaps
the example.
Yeah, I was going to say perhaps for liability reasons, but they don't always all have the same insurance or are in networks anyway. Yeah, go ahead.
I was just going to say, I mean, like some of the examples are anesthesia, that you don't really choose your anesthesiologist. So you could be a woman going in to give birth. You go to an in-network hospital, you go to an in-network OBGYN who's going to deliver your baby, but the anesthesiologist who put you in your epidural, that you didn't really have a choice of who that anesthesiologist was, they're out of network by design, and then they can send you an out-of-network bill after the fact. And they say that a little bit of the No Surprises Act, or a lot of the No Surprises Act, was due to the buying of private equity firms buying up a lot of anesthesia groups, and that was one of their go-to strategies, was to bill out a network. So it's a shame, because I do understand the reason for. I mean, as a doctor, I'm looking at it from that perspective, that doctors are trying to bring in enough revenue to pay their bills. I mean, our expenses are going up, and our salaries aren't necessarily going up. And I'm not trying to, I know not everybody's got sympathy for doctors. I get it. But the thing is that they're not just doing it to be greedy, is what I'm saying. Maybe the private equity firms are, but the doctors individually aren't doing that. So now they don't have that ability to bill out a network for those funds. The thing that's interesting, though, is the No Surprise Act doesn't apply to ground ambulances. And now the ground ambulances can still send you out of network bills, and they're still getting tax revenue from the city or county that owns that ambulance company. Just an aside.
It's definitely, none of these regulations, laws, are perfect. We know that. From my perspective, the whole thing is, and I always give Cy Sims. The stores are no longer in business. I'm not sure if you know who that is, but in the Northeast, there was a clothing store called Sims, and their motto was, "An educated consumer is our best customer," right? And how can you be educated when there's absolutely no access to data, right? And it's as a benefits advisor, I have the luxury of working with a lot of employer groups, and when we go to open enrollment, that's when we hear, the sad stories, and a lot of times maybe they don't feel it's their place, or they don't want to bother us. But when you go to an open enrollment meeting, and someone who you've agreed to meet afterwards because it was a kind of a personal situation comes up and says, "Can you help me? This happened to me. I got this bill," and they have the paperwork ready because I know I'm coming. And maybe the HR director said, "Yeah, please, Lou's very approachable, whatever the case might be," and it's infuriating. And you're right. I disagree with one thing you said. I have a tremendous amount of compassion for doctors, because the managed care system that they've been forced to work under for the last 30 years, it's like we're playing a game that we have no control over the rules, and the rules just keep on changing. We're not allowed to read them. We don't know what they are. So we don't know what to ask for, and unfortunately, at least here in the Northeast, and I would imagine probably in your part of the country as well, a very high, significant percentage of doctors have sold their practice to the healthcare systems that operate in their neck of the woods. And, a lot of that, I think, probably was because those healthcare systems can negotiate bigger rates for them, higher rates for them, but also they can absorb all of that administrative burden, and, the expense of running an office, right, can be taken off the doctor's shoulders. And hey, you're a doctor, go back to being a doctor. That's what you went into practice for. And that probably sounds really appealing. And then they realize, well, they have a boss, and that boss wants them to see a certain number of patients a day. And typically, and this comes right from doctors I've spoken to, they have about enough time to see a patient every 7 minutes. And you cannot be a doctor. I don't know how great you are. You cannot properly diagnose a high percentage of people in 7 minutes of seeing them. They're typically standing at a desk with their back to you on the computer, entering the notes as they're talking to you. Hopefully they're entering your notes. not the patient that they just came from. But, I think that the whole system does not work for the clinicians. It doesn't work for employers. It doesn't work for members. I call them members and I call them patients. They're members when they buy insurance from their employer, but they become patients when they start to use it. And a lot of times you're making a decision at open enrollment to select an insurance plan based on your ability to pay for that. But then you find out when you go to use it that it's kind of worthless a lot of times. There's so many plans now. I think the average plan has over a $2,000 deductible, and that's in network for inpatient, outpatient, radiology. Sometimes it's for everything. If it's a HSA style plan, that deductible applies to everything but preventative care, and it's a real sad state of affairs when you have no access to price. I spoke to I won't mention them. It's a really well-known retail chain here in the Northeast a few years ago, and I was talking about pricing, and I could see them getting very uncomfortable there. And the reason was, they said, after I stopped talking, they said, there's a penalty of about $10,000 on us as a retailer if every item on our shelves doesn't have a price on it, or if the wrong price is posted. You can't go into a fast food chain without every item on the menu being on their tote board behind the register and the calories. Mm-hmm. But for some reason, and these are these regulations, these are our elected officials that drafted these things up. Some of them are federal, some of them are state, but for some reason they didn't think that was important when it relates to healthcare and health insurance, which are the number one cause of bankruptcy in this country, and that's people with insurance. So it just really it's time that this take place, and I think it's going to be slow but surely. I don't think this is going to be reeled back in, and I think that it really is up to the consumers out there to use it, right? If you want to pay less for your health care, you need to use the information that's out there. If you want to pay less for health insurance, the only way to do that is pay less for health care, because your health care costs dictate your premiums, right? For all of our clients, we're trying to instill that in them, that we're not shopping for insurance. We're trying to fix your health care cost problem. If we bring that down, then the overall cost to insure that drops down as well. And a lot of times the way to accomplish that is by improving the care, offering employees incentives to be a consumer, to use the information like what you showed us to get an estimate. Don't go to just the first place you're going to go to. I'm curious, if you, as you were showing me that, I was thinking, does the provider have the ability to reduce the cost that's on that statement? If someone comes in, like, you're buying a car, right? And you go to one dealership and you get a price. You go to the next dealership and you bring in the written price and say, if you could beat that by $25 a month, I'll buy the car from you. Can that happen under the No Surprises Act? Do you have the ability to say, oh, instead of $5,000, we'll take $1,000 off? Is that?
Yeah, I mean, certainly from a cash perspective, like, for cosmetic procedures, there might be some negotiation going on, but I do know that there are some laws against the inurement of trying to lure people away. Things like, oh, you don't have to pay your deductible, things like that. I know that's definitely codified in law, that you certainly can't do those types of things.
Okay, right. It's not like it's like automobile insurance. I have 2 cars. Anybody who follows me on LinkedIn, I had 2 cars in front of my house destroyed by a drunk driver 2 nights ago. My daughter's car is absolutely totaled, and my auto body shop, who loves us because we've been hit probably 15 times over the years, they couldn't believe this one, but they don't play that game, right? And a lot of places do. They'll just say, bring it in. They inflate the price. They get more from your insurance, and they say, what, we'll at the end we won't charge you your $1,000 deductible, or we'll give you $500 back. I could see how that is not the purpose of this legislation.
Right.
at all.
Yeah, and I definitely feel like when I provide my pricing information on my website, and when patients call to schedule a consult, we actually, even if they didn't check pricing on our website, we use that system I was showing you. We send them, we email them an estimate so they have a better idea before they come in. So I don't know that that's necessarily connected, but I do feel that if I'm going out of my way to provide you with all this pricing information when you come in, if that is the right procedure for you, then that's the cost.
Right.
I'm not motivated to negotiate with you. One is that's just not something I enjoy doing. And I guess because it's a medical procedure, maybe I feel even less interested in doing that.
Yeah.
But I feel like I'm I've maybe I shouldn't feel like I'm doing them a favor by showing pricing because that's the right thing to do. But I do feel like acknowledge the fact that I'm providing you pricing, so when you come in, you are prepared for that.
Right.
There's not this ongoing discussion of trying to negotiate it down.
No, and I
That's
respect
just how
that.
I feel. Yeah.
And I respect that because, more important than cost to me, more important cost is quality. When we talk to our employer groups and prospects, we don't talk about paying less for insurance. We don't talk about paying less for healthcare. We talk about eliminating the hidden profits and driving your employees towards the highest quality. It just so happens that very often the highest quality provides the lowest price because those are the doctors that are doing things in volume. They're an expert at it. They're so efficient and effective of what they're doing that their price is, typically less money overall, right? And it's a little bit different, I think, when you're talking about cosmetic versus non-cosmetic, surgeons, things like that, because in the cosmetic surgeon world, you're not dealing with insurance companies as often.
Right.
So your prices are a little bit more simplified. You don't have a price for every single insurance company that you work with, right? People don't realize that. The price when you have an employer-sponsored plan with Aetna, Cigna, Humana, Blue Cross, Anthem, Oxford, United Healthcare, Emblem, it's different every single time. Maybe the charged price is the same because they just have a number, like in hospitals, they call it the charge master. This is what they spit out. And then what they get back is the allowed amount. That's typically the most important component of your in-network plan. Is billed is one thing, allowed amount, especially if you're in-network, that's the most important because that's ultimately the amount you're going to be held responsible for after the insurance company determines what they're going to pay. You have co-pays, you have deductible, you have co-insurance, things like that. I think it's this was really an awesome presentation because I think it gives a chance for the consumer out there to see what's possible. It's happening already. It's just not happening, at a majority of facilities. Now you are working. Your technology is available to other providers, right? I mean, this is
Right.
you're making them, and I don't know if you covered this just now, but I remember very distinctly from Phoenix, is that this is a lead generating system for them, which doctors really don't have the ability to do now, right? They know who the people that are out there searching for it. They now can start creating a database of potential, I don't want to call them prospects, but in essence, that's what it is. It's really entrepreneurial of them, but it also puts them in a position where, I know as a consumer, I don't want to go to that car. I'm going to be shopping for cars for my daughter, with my daughter, not for my daughter. I'm not going to go. I just don't want to drive to 15 dealerships.
Right.
I want to be able to get an idea ahead of time. What's it going to cost me? Right.
Yeah, I mean, the price transparency, I know that it's taken a while to get to this point, but with the Trump era price transparency rules and the No Surprises Act, the momentum, we've been pushed along decades just with that federal intervention, which sometimes federal intervention is good, sometimes we're not so excited about it. But from the consumer perspective, we've really moved along really quickly here. But as far as the lead generation aspect of it, I think most doctors don't think of that as being important because they've just always been in a network, and then the network provides them the leads. They've never had to be a little bit more proactive about it. But that's the thing, is that they are going to have to be more proactive about it because now patients are going to start to shop around, even though I don't like to think of it that way because they need to be looking at quality, not just cost. But patients will be looking around more. They're going to realize that they don't necessarily have to stay in network, that the least expensive rate with good quality isn't necessarily the negotiated rate. It might be a cash rate. It might. So as they start to search around, you need to be the doctor or the ASC or the other type of facility that allows consumers to check pricing information through your website, whether it's cash pay or insurance based. That's possible. As I showed you, that it's a way for them to check their insurance based pricing and determine their real time eligibility and all that. That's what you need to be in the mindset of, making it easier for the consumer to check pricing on your website so that you get a lead in return, so that you can find out who that patient is. Because again, they may not be in your network, and you would be leaving, they would be going someplace else to a doctor that maybe is more price transparent oriented. And that's why this is so important for all providers, not just plastic surgeons, even though people think this is just for cosmetic surgery because I'm a plastic surgeon. Hopefully I've demonstrated that it's not, in the sense that you can do it for insurance and bundled pricing as well. But yes, exactly right. People need to be thinking about this, unfortunately, more as a business, because there's going to be more competition, because patients are going to be a little bit more in control. That's why you talk about consumerism. It's shifting, the weight of the scale is being shifted towards the consumer to be able to go out and determine the best place for them to go, whether it's based on price or whether it's based on quality. And you need to be able to have the capability of capturing that patient that's searching around.
Well, it's funny because employers that sponsor health plans, they don't think of it this way, but they're running an insurance business, right? It's their second or third largest expense. I think it was the CEO or COO of GE that famously said, we're basically an insurance company selling steel, because it cost them more for insurance than steel. But you have to think about yourself as a consumer. When you have your ID card, I have a close friend who called me probably about 2 months ago. She has a high deductible health plan that she bought on the marketplace, and she knows what I do for a living. She's not a client or anything, but she said, "Look, Lou, do you have 5 minutes to talk to me? I have a situation." So she needed a simple X-ray, but she has a $4,000 deductible plan, and she was shopping around, and $400 was going to be the cost. So I said, call those places back again and tell them you want the cash price. Because you have an insurance card, that price is typically artificially inflated. And I'm not talking about the charge price, the paid price. Insurance companies pay more than what a doctor would accept without insurance. Her price was $45 for an X-ray that they were going to charge her $400 for. That would have come out of her pocket. It would have gone towards her out-of-pocket limit, but it was out of her pocket. At the end of the day, she got it that day for $45. Doctors want to get paid cash. A lot of times they get paid on the day of service. And, typically, a lot of out-of-pocket cost goes to bad debt, right? I worked for a very large radiology practice right out of college, which gave me a lot of insight. I did billing, I did collections, I did the daily receipts, I ran to the bank. It was an ungodly amount of money. But doctors want to get paid up front, because if they don't get paid and you have that $3,000 deductible that comes even in network, it's a surprise to most people that it's going to cost them that much money, because they don't know up front what an MRI costs or what a particular surgery or test costs. So it might not fit the official definition of a surprise bill, but this is a surprise to everybody. Yeah. They'd rather go to collection than pay it. So doctors are business people. I think they've been forced to become more with a lot of the legislation. And I think that the ones that embrace this have an opportunity to really drive more business to their practices, because I think, as a business, if you could be truthful with your consumers and not try to hide the truth, I think everybody will do better. And I think that goes for all types of business. So I shared a slide here. If anybody wants to reach out to Dr. Kaplan or myself directly, here's our information. Feel free to email us, call us, follow us on LinkedIn, whatever the case might be. It's been a real pleasure to have you on the show today. Thank you.
Thanks for having me.
As Joe Pesci said, you've been a lovely, lovely guest, witness. So anyway, thanks so much. I'll look forward to speaking with you again. I don't know if are you going to Benefits Pro in Austin?
No, I won't be going, but I know our paths will cross somewhere along the line.
Absolutely. Sure. I'll talk to you real soon. I really appreciate it. Thank you so much.
Thanks again for having me. Take care.
Take care. All right. Bye-bye.
Bye-bye.